morning, everyone. This is Tracy Berardi, Program Manager of BPM Plus Health. I'm here with my colleagues at BPM Plus Health and the OMG for our community update session. So glad you could join us today. We launched this community back in September 2019, and we're really excited to tell you about all of the progress we've made in just 10 or 8 short months. So we're going to get started first with Ken Rubin, the Executive Director of BPM Plus Health. He's going to give us an overview. We have a couple of great guest speakers, and then the chair of the working groups will update on their activities and next steps. So Ken, the floor is yours.
Great, thank you, and apologies. I didn't realize it didn't occur to me to webcam, and I didn't have that set up this morning, so I'm just a disembodied voice. Thank you all for making the time. I know things are a bit crazy these days, and I appreciate your spending a little bit of your day with us. So I'd like to talk a bit about the overall BPM community, just a touch of background on what we're about for those that are joining us for the first time, and then really spend the bulk of the time talking about really what's been happening since the last time we've gotten together. So let's see if I can advance the slides here, or next slide, please. There we go. So what problem are we trying to solve? If you look across the healthcare spectrum today, processes and best practices, and this isn't new to today, they're ever changing, but one of the things that is kind of unique at the current point in time is our understanding of, through COVID, that what is considered the right thing to do, the best thing to do for patients and patient care. I think never has it been clearer than it is right now that's a moving target. And as a result of that moving target, it's really hard for institutions to keep up. Once you decide, what it is you want to be doing and how you want to be practicing it, how do you actually put that into practice? Every discipline, professional society, and organization uses their own language to express their best practices, their clinical pathways, their workflows, which makes for the consumers of that content, that adds some challenges. You need to be able to understand what it is that the authoring organization is trying to say, interpret that, probably interpolate in some cases if there are gaps or ambiguities in what you're reading, and then figure out actually how to put that into practice, which ultimately leads us to this notion that adoption of best practices is difficult. So I want to spend a minute, the reason I want to spend a minute on the problem is this sets the stage for ultimately what BPM Plus Health is all about. So if we're to look at that problem set and want to advance that, how do we solve this as a vertical? And one of the keys, in my view, is to start to converge around a common language, a common way of expressing these needs, so that we can have tooling to support the development of these best practices, to advance the consumption and implementation of those, to, in effect, kind of flatten that entire life cycle that currently is 17 years from research to practice, and see if we can't really remove a lot of that time, certainly at least on the technical implementation side of things. So that's really what this is all about. So the BPM Plus Health community was established to take that on head on, to foster and enable the sharing of best practices. I focus clinically. My background has been largely around the clinical side of things. BPM Plus isn't exclusively clinical, but I do tend to go there, so forgive me for that bias. It's based on a set of open standards and expression languages. You might have heard of Business Process Model and Notation, BPMN. That is one of several of these visual languages that we leverage. It's supported by commercial tools, and we've got more and more implementations coming all the time. And the focus is on advancing this concept of shareable, interoperable processes. So no longer is it sufficient to have a process live just within one institution, as patient care spans institutions. People go to different sites of care, different settings of care, and often in different organizations. So that's really what BPM Plus is all about. If we could move to the next slide, please. So what is BPM Plus? It's a community of practice to advance this concept of shareable pathways. We officially launched, as mentioned, in September of last year. We were able to secure kind of out of the gate endorsements from several organizations, HIMSS, HL7 NCQA, et cetera. And I'm happy to have Chuck Jaffe representing HL7 here with us today, who's gonna give a few words. We're operating under the Object Management Group. For those not familiar with the OMG, it's a 501c6 industry trade consortium, nonprofit, and has a long history of developing open consensus standards. So OMG's been around for, Tracy can correct me, probably 30-something years. I can't remember exactly how many.
31 now. Yep.
Thanks, Tracy. For 31 years. So it's in a safe set of hands, and that provides this kind of level playing field environment for folks to collaborate, including direct marketplace competitors. Next slide, please. So what are some of the tenets of the community? How do we operate? This is a value-driven peer community. So the idea is to bring together peers from all different parts within the health sector to be able to collaborate, share lessons learned, and ultimately raise the bar around how these pathways can be used, leveraged, and advanced. We operate with openness, transparency, and trust. The work products of the community, everything that we're developing under BPM Plus is freely available. It's unencumbered from IP or patents infringements. So you can take that content, pick it up, use it. You don't need to attribute it, although we wish you did. But that's available to anyone at no cost, whether you're a member of the community or not. Similarly, anyone that's interested can dial into one of our calls and start to participate. Not everyone has the same privileges, so being a member of the community, and memberships are organizational, that does bring privileges, things like the ability to take on leadership roles, to do voting, and so on. There are other benefits of being a member, but not being a member doesn't prohibit you from getting involved. One of we put this into the FAQs, but there's this perception that the BPM community, we vet, that we curate, and then we develop these care models and workflow models, on behalf of the industry, and that's really not what we do. What we do is figure out how to use standards and languages to allow for that effective sharing, and put out guidance, like a style guide, to help people do that, help train people to be able to do that effectively within their own organizations. So we're not the approver of models. We're not coming up with, the be-all, end-all, hypertension management, protocol, for instance. But what we are doing is allowing member organizations and non-member organizations to be able to take their hypertension guidelines and document them in such a way that if or when they choose to share them, other people can pick them up, use commercial tools, and then embrace them and consume them. And in so doing, do this in collaboration with a broader community. So as collectively we figure out, how do you solve this type of a problem, we can share that within the community so people can consume and use these things effectively. Next slide, please.
And Ken, I just want to pause for a quick moment. There was a note in the chat, and can everyone see this PowerPoint slides in addition to webcam? I checked the audience view, and but I just wanted to make sure. You can see them, right, Ken, from your side?
Yes, I'm seeing the PowerPoint.
Okay, thank you. Sorry, you can continue.
No worries. So how are we structured? We've got 5 different kind of focus communities on different topics, and I'm not going to dwell too much on this. So I'm just going to very quickly introduce them. These slides will be made available, so you'll be able to peruse them at your leisure. We've got a community on authoring, which is about how to create these pathways and document them. We have a community around institutional adoption. How do you bring one of these models inside your organization and actually put it into practice, whether it's a clinical thing or an operational activity. We've got a community around implementation, the actual running of software. How do you create models, ingest models, execute models, and so on. By the way, I failed to mention that one of the potential benefits of this type of approach is it allows for the direct execution of these types of models. So these aren't just glorified paper documents. These are actually, kind of high level, execution. I don't want to say software code, but it in effect, it can be executed. The fourth work group is what we call methodology, which is looking at the core notations. How do they fit together? Are they fit for purpose? Are there gaps that we need to close? We've actually identified a couple of new notations that are necessary, and those are in the works. And then the last group is the academic and professional education, which is looking at establishing curriculum, coordinating with medical schools and other academic institutions, working with private sector entities to advance training and professional consulting, et cetera. So that's the way our community is structured. I didn't specifically mention our COVID activities here. We do have a couple of projects related to COVID, and we've got an update from each of these work groups in just a few moments, and a deep dive on some of the COVID work tomorrow. Next slide, please. So the big picture, COVID has definitely affected us in terms of how we've been working as a community, but not terribly adversely affected us, I don't think. We had a face-to-face meeting in December. Our intended March meeting was made virtual, as are all events these days. So we've adjusted. We've had to slip just a couple of things, and I'll talk to that in just a minute. But for the most part, I think we're rolling along very, very well given the impact. I think COVID has actually created a massive opportunity for BPM Plus, because as I was mentioning in the introduction, the idea of having to keep pace with the ever-changing body of medical knowledge, that's something that, prior to last year, I'd had many conversations with all types around that. And your clinical quality folks, your health informaticians, your kind of leading edge providers were very, very interested in that. But most of the mainstream, again, I focus on the provider side within the health segment, weren't as interested in that. So they've been practicing medicine for a long time. A lot of the emerging cutting edge stuff didn't necessarily apply to most day-to-day encounters. So I won't say there wasn't an appetite for that, but there certainly wasn't a strong demand signal for that. But COVID has changed all that, because the right thing to do is, we don't know what it is, and what was the right thing to do 3 weeks ago may not be the same guidance that's today. So in that regard, speaking very, very selfishly for the community, COVID's actually done us a favor, because it's given us a front and center stage to why this type of work is important. So I wanted to spend a moment on that. We're looking for more implementation pilots and interest. We have several pilots going on. We've got an implementation showcase tomorrow you'll see more about. We're within each of the work streams. Most of those work streams are now at the point where they're highly functioning. A couple of them are still kind of coming into that. We're only 8 months or 10 months, or I guess 9 months old. So we've covered an awful lot of ground in that time, and we're getting better all the time. So that I'm very excited about where we are with that. Our industry presence continues to grow. We're working on, and have had several papers accepted. We've got many conference presentations coming up. In fact, there's a conference next week where I know we have a poster being presented. So we're really starting to step out in terms of coordinating with other parts of the community. And the core specification work really continues. I mentioned the core spec of business process model and notation. There are two other kind of essential specs, the case management model and notation, CMMN, and decision model and notation, DMN, and we found several others that are also relevant and are under development. Couple of very, very nuanced details for those that are kind of in the community. We now have a collaborative site up and running that had been a real obstacle for us. Logica Health has been kind enough to provide us with Confluence access, and that's been a real game changer for us. The website continues to improve. We've got a number of education sessions available on demand. and training, and several of these past presentations and many of the sessions from this week will go up on demand. And we've started to cross-coordinate within the community with the acting co-chairs. Next slide, please. So very quickly, I've got, I'm going to run just a minute or two over, but I think it's important to cover these. So 5 things to know since March. So for those that haven't been following us closely, we've got 2 COVID-related projects, the COVID Navigator or Placemat, which is intended to solve the, what are the magic keywords that I need to use to find the asset that I'm looking for problem. So instead of having to kind of divine, how to do my search, how do I start to actually browse what's out there and find related stuff? That's what the Placemat is. And we've got this kind of point of care emergency room assessment app, which is allowing for the discovery of the state of EDs. This is something we're doing in collaboration with the American College of Emergency Physicians to help avoid emergency rooms in crisis. So both of those we'll hear more about over the coming days. Community governance. We'd made a commitment last September to institute, formal governance bylaws, policies, et cetera, come September. I'm sorry we're going to have to slip that a little bit. I did a lot of inquiring across the community with members, and the sense was we're just not quite ready yet, but we are going to meet the spirit of the commitment, not the letter. We plan to have bylaws and policy documents available in September, have a 3-month vetting period, and then in effect hold open community elections and institute all of that come the new year. So it ends up being a 3-month slip, and if anyone has concerns about that, please raise those in the chat, and we're happy to figure out how to work through those concerns. We've established a clinical steering committee. It's part of the authoring group. It may end up with a bit of a broader remit. Today, I'd like to announce Shane McNamee as the elected chair of that group. All elections at the moment are interim appointments, so this is until the governance kicks in on January 1, and that's true for all positions associated with BPM Plus. But we welcome Shane into leading that effort. We've been partnering with Duke University in some of their informatics capstones, and they now have some active projects running where they're assessing some of the tools available, some of the educational materials available, and how those get applied to some real-world use cases. So we, applaud the work that the Duke students are doing and the academic outreach folks. And then we've mentioned previously that we were going to have a BPM Plus award focused on the impact to an individual patient. We've elected to slip that to 2021. So a lot of the energy that had been going into the award was redirected into the COVID projects. So that's one that wasn't, immediate critical path. So we've delayed that. Next slide, please. So by the numbers, and I'll do this very quickly, and then we'll wrap, and just slowly click through these. So we're growing and growing quickly. We've got 13,000 website hits, 2,600 people on the list. I think the fact that we've had over 3,500 video on demand is a great metric. It's a telling metric for how well things are really starting to pick up. The field guide, which is kind of the Bible for how to use this stuff, we've had over 600 downloads, which I think is significant. We've got 37 members. Keep going, Tracy. 17 ambassadors, 10 co-chairs, 5 working groups, 2 COVID projects, 1 community, and less than a year since launch. So there's an awful lot going on. I'd like to applaud everyone that's been involved in this, whether you're leading an initiative or just someone who's been showing up on calls and making active contributions. Because ultimately, this is about advancing what your individual agenda is and how that aligns within the fabric of the broader community. So with that, we'll end with my current priorities. Oops. Yeah, at least wait a second on this. So we're working on a whole host of minute as we get the work group updates, assessment guides, maturity model, authoring guides. So you'll see there's just a large diversity of work that's going on. We're in the process of establishing test beds. We want to have, cloud-based test beds for people to be able to come in and kick the tires and consume some of the stuff. So that's underway. Actively working on pilot implementations, and you'll hear about a lot of those tomorrow. We have a collaboration going with HIMSS, and had planned a massive presence at HIMSS this year. Obviously, that didn't happen, but we're working toward 21 on that, and then finalizing the elections and the member benefit. With that, I forgot I'd reorganize the slides, and then just my contact details. And what I'd like to do is pass it back to Tracy. We'll hold questions and bring that back up at the tail end, if there's time. But thank you all for joining us, and I'm looking forward to hearing what our remaining speakers have to say.
Thank you, Ken. That was a really good overview. Great. And yes, we're saving these slides, and we'll post them also to the BPM Plus Health website. So we have a couple guest speakers joining us today. This is ahead of the updates from each working group. So we're really happy to have Chuck Jaffe, CEO of HL7, to say a few words. Chuck, welcome. Thank you so much for joining us today.
Thank you. This photo was taken as a candidate at the last AMIA meeting. I must have been in much better spirits then. In any event, I did want to thank OMG and the leadership of the new evolving program for inviting me to this virtual event. As you can imagine, for the past 5 months, HL7 has been involved in delivering for the COVID-19 pandemic by addressing the data needs in the transformation of patient care and public health and research. As many of you know, for 3 decades now, HL7 has really thrived on collaboration, and we've contributed to the success and maturation of the health component of OMG for more than a decade. When BPM Plus Health was launched in September, HL7 became one of the first supporters of the organization. We continue our enthusiastic collaboration with BPM Plus. Within the 5 BPM Plus work groups, HL7 members participate in virtually all of them. We collaborate at many levels. In fact, the HL7 CQL standard, clinical quality language, is now used in part for its contribution to the BPM Plus standards. Perhaps more importantly, HL7 FHIR is leveraged within clinical systems that are now providing real-time data to inform workflow expressed in BPM. And in addition, the HL7 ECR Now specification for case reporting to public health agencies has now been promulgated and supported through the CDC. At its international meeting in Sydney in January, HL7 co-sponsored a BPM Plus workshop that was very widely attended, and a lot of success emerged from that. So thanks to you, Ken. We have enjoyed a long-standing collaboration with a host of the organizations that Ken referenced, HSPC actually emerged from a work group at HL7 and is now a freestanding organization, Logica. But we also partner with AHRQ and HIMSS and NCQA. In fact, on July 22nd and 23rd, HL7 will jointly host our 4th Digital Quality Summit, bringing together the voices of healthcare quality. That'll be a virtual event, and I look forward to seeing many of you there. Now that HL7 Fire has become an integral part of the final rules, both published by ONC and CMS, we expect even greater collaboration with BPM Plus to emerge from that process. So again, I wanted to thank everyone. I look forward to meeting with some of you, and I managed to do that in 5 minutes. So if you want a couple of questions, I'm glad to try to respond. Otherwise, thanks again to BPM Plus Health.
Thank you, Chuck. You know, that's okay. I'm sure, knowing us too, we take all the time that we give ourselves. So, but if any questions come in, thank you. I'll look for them in the questions box. Next, our next guest speaker, Tom Naughton, President of MAXIMUS Federal Services. MAXIMUS is gold sponsor of the BPM Plus Health e-workshop this week, and a huge supporter and participant in our community across the working groups. We're very glad to have you join us this morning, Tom, and thanks for saying a few words.
Thank you very much. Really appreciate the time today. And yes, I am Tom Naughton and not Lisa Beath, if anybody's confused. So we clarified that. That's good. As a long-term frustrated BPM executive for years participating in technology-related organizations and listening to technology and IT keynote speakers and sort of having BPM pushed to the side, MAXIMUS is definitely an enthusiastic supporter and participant of BPM Plus Health. It's a refreshing organization. I think it's really motivated and excited us, and we are just very happy to be part of the organization. And I thank you for giving me a few minutes this morning to talk about some of the things we're seeing in the new normal here, and what we're learning from that. I just lost my video, so there now I can see better. So just a little bit about MAXIMUS. You know, we're a 40-year BPM company focused in health and human services. We only work for government, so we've got a very good, I think, sight on evolving government policies and practices. As clinical workflows, you know, we really look at clinical workflows as the BPM of healthcare, and we're very focused on helping improve the ability to provide clinicians with current and accurate clinical workflow guidance through EHRs and other associated workflow tools. And we really see BPM Plus as bringing the community together to directly address this issue. I think one of the things I've always appreciated about working at MAXIMUS and the culture we've developed, you know, within our culture, we believe we have an obligation and a responsibility to provide whatever assistance we can to ensure access to quality of health care to all communities in the United States. And that's really been our mission since I've been part of MAXIMUS. And I think that's a focus that is part of BPM Plus as well. And I think that that's a focus if we, particularly in this new normal, think about that as an important obligation of all of us. We're going to have some significant achievements going forward. Just a little bit about, what we've seen in COVID, with Maximus. We've done a lot of work with HHS, which I'll talk to you about in about a minute or two. And we're also supporting a number of states, both in the testing and the tracing. I think since March 15th, we've deployed approximately 2,000 people across the U.S. supporting states in COVID tracing efforts, testing efforts, as well as tangential efforts, things that have been impacted, such as unemployment insurance as well, where states need significant assistance. I think today I would just really share 3 ideas as we continue to work through COVID and see what's going on. I think it's number one, it's already been touched on by Ken and Chuck, is the importance of data accuracy, data integrity, and visibility, and analytics and modeling. If you look at what states are doing as it relates to testing and tracing, they have many programs. It's really a patchwork. And so you'll have, I'm in Virginia, and it is very unclear whether Virginia shares its data with DC and Maryland or any other states for that matter. It's also based on the states I've surveyed and my understanding of the federal testing program, there is very little, if any, electronic data collection at the testing sites. So you'll have a state that will have private testing sites, state public testing sites on federal Army bases, and then federal community-based testing sites. None of that data is collected electronically at the beginning of the testing process. All of those folks are generally on different systems, hopefully with the goal of getting all that data to CDC and collecting the same data. But based on our work and our observations, that's not happening. And I think it's created a lot of data integrity issues, and obviously has significant impact on analytics as well. So I think continuing to work with state governments and the feds as they're engaged in COVID to really try to get a uniform data collection and get electronic data collection as early in the process as possible, and then trying to share that information with folks as much as possible is obviously key to helping address COVID and its associated consequences. Another issue I'd like to bring up that we've observed is really, and this is more on the state side because there's been more activity on the state side than on the federal side, but really getting states to, from the conversations of we can't do that to how can we do this, and really engaging with the private community to develop private partnerships on how to build an effective response to COVID, and whether that's with a direct COVID program or with a indirect COVID program, such as assisting states in unemployment insurance. So historically, states would never contract out unemployment insurance work. It's all government, inherently governmental work, and has been protected from outsourcing. States, probably 26 states have outsourced contracts to provide unemployment insurance support, and are allowing public-private partnerships to help address that. And they're looking to evolve those programs from short-term surge support to long-term operations support. And then on the COVID side, what you're really seeing is states understanding that they need to move much more quickly than they do historically. So we are, seeing contracts be released, negotiated, and implemented within 7 to 10 days with, hundreds of folks involved. And you're really seeing states break out of their shells and wanting to collaborate more, sort of discuss what the best solution is with contractors to address COVID in the most effective ways possible. So that's been a very interesting observation as well as those relationships evolve. And then I think just the third one is really collaboration and the importance of it. And we're seeing that. I think a good example of that is Health and Human Services manages federally community-based testing sites. So they started with 47 testing sites across 12 states, and we've supported HHS in providing the test results to the folks that get tested at those sites across those states. And it's not only HHS collaborating with us, but HHS and Maximus is collaborating with the state health departments as well, and really working together, as I said, to collaborate and get the most effective programs up and running. So it's been refreshing and positive to see the importance of not only the feds and states working with each other, but also working with a private entity to make sure best results are achieved. So I think in closing, it's really just, as it relates to COVID with our observations, I think data is key. And I think data is key as it relates to clinical workflows as well. And I think that needs to continue. That needs to be a significant focus going forward. And I think if we can improve the data collection and the data integrity, that will obviously provide much better results down the road. And then I think I would just underscore, if we remember and keep in front of our mind that we all have an obligation and responsibility to assist in providing access to quality health care across all communities. I think that is going to, again, lead to great successes. And I think I can only thank Ken not enough for the BPM Plus health community and his organization of it. And I think it's a great effort, and we're really proud to be a part of it. So thank you very much for giving me the opportunity for a few minutes here.
Thank you, Tom. Those are all very good points, and we appreciate your participation and support. So the next segment of our session today, we have 5 working groups that are fully functional and doing some great work. So the co-chairs of each group will spend about 10 minutes just updating the community on their projects and work for the rest of this year. So we'll start first with the authoring work group and make our way. So the authoring work group is co-chaired by Amy Stowers from Maximus and Pawan Goyal from ACEP, the American College of Emergency Physicians. We'll also hear from Shane McNamee, who is chair of the Clinical Steering Committee, which works closely with authoring. So Amy, I'll hand the presentation over to you.
I'm unmuted. Thumbs
There
up.
we go.
I'm assuming people can hear me, or you would tell me differently. Okay, great.
Yep, we can hear you.
All right, so
Welcome.
folks, thank you all. Thank you all for the opportunity. Great presentations. I'm going to build on what Ken and the others have already discussed this morning, and we're going to tag team the authoring work group. We've got Shane on board, who's chairing our brand new Clinical Steering Committee. that is part of our authoring work group, newly aligned. And so Pawan's going to give part of this brief, as well as Shane's going to discuss the newly formed clinical steering. And I want to give a shout out to Carrie and to Sharnita, who facilitate our groups and have been a key in our transition over to our new collaboration site. We would not be anywhere near where we are with our progress without their dedication to us accomplishing our objectives. Now, just to recap, and we kicked off 2020 in February. We had our first really good work session in March that was virtually. And as Ken said, we've made a great deal of progress with a lot more to go, but we're really excited about the work. We've made progress on a lot of fronts. One, a focus on deliverables, as well as the interoperability or integration with the other work groups, and I'll speak a little bit to those. So we've got 3 quick slides that we'll go through. The first slide shows you our current activities. And again, focused on engagement, everybody having a voice that calls in, and or using our new workspace, our new collaboration space for people to sign on, give comments to what we are doing outside of our work sessions. We have elaborated on our aim for the authoring work group. We're going to cover that with you. And we have really Carrie has kept us on point in our work sessions around delivering the why, the business case deliverable of why BPM Plus Health is so important, and developing that document. Next slide, please. I think at this point, Shane, we're going to turn the time over to you, and you're going to talk a little bit about our clinical steering committee, please, sir.
Yeah, thank you, Amy. Greetings, everyone. I know many of you out there, and those who I don't. I appreciate you giving me a couple of minutes to talk, and I appreciate you tolerating all of the birds who are happily singing outside of my office. Shane McNamee again. I want to give huge kudos to Pawan and Amy and Carrie for all of the work that's been done in the authoring work group up to this point. The clinical steering committee is being formed right now by a group of us really to drive the aims that are in front of you, right? Is to start to put a framework and some parameters in really how do we start to drive the BPM Plus Health message and tooling forward into the marketplace at a period of time of rapid change in healthcare, great need for tools like ours and like the things that our open source community brings forward to really start to solve some of the major public health crises that are slamming into our country right now. Call it COVID, call it suicide and opioids and diabetes and hypertension before those, but there is a great awakening now that we need to change things and to reshape them. So clinical steering community, group of us, I'm not going to list everybody because I'm going to forget somebody, so my apologies for not doing that, but there's 6 of us all together. We're really at this point promoting the community inside and outside of BPM Plus Health inside, but also across others. Spend a lot of time working with HIMSS and IHE, the strategic planning there, kicking open some HL7 and FIRE collaboration work. There's an office hours initiative that you're going to hear about a little bit later on, which is an opportunity for really the community at large, the community at large to get together under this grand OMG umbrella to get together with technologists and with business people and with clinicians and really start to look at the problems that are out there and what are the practice patterns we need to move towards, because we're at a really important time with this initiative. And you know, Ken said something at the top end, which is the adoption of best practices is difficult in healthcare, which coming from a healthcare provider standpoint, and all of us do, we love best practices. We love things that we know that we're participating in the care of a patient or a group of patients when they're moving through their pipeline towards health or at least away from hospitals. We love it when those things are there. I was a polytrauma physician for a lot of years, traumatic brain injuries and war wounded, and we got the units humming to the point where you could go home on a Friday night and come back to work on a Monday morning, and everything was okay because we implemented best practices. The challenge up to this point in this dawning computer age is that human beings, clinical providers, have turned into data entry monkeys and information mules between systems. We know that processes that exist across boundaries for patients are those. We know that at those boundaries from a business and a technology perspective is where the greatest value is delivered. But up until about the last 5 years, we had a major technology problem. We couldn't get past that. Then comes fire. Amazing. All of a sudden, we now have atomic data that's computable that we can use and orchestrate care across, right? Then we have the cloud revolution, and then we have COVID. And all of a sudden, we're waking up to the fact that we need air traffic control systems for healthcare. Better yet, a public health utility for healthcare that makes care better, faster, and cheaper for everybody over time, which are the tenets of automation. And we are the people that OMG has blessed with their time and their energy and their investment, as they have other groups in the past, to do the exact same thing for healthcare that they've helped usher forward otherwise. So Clinical Steering Committee is coming in to help take that investment and really help to shape how, at this very small window that we have with this standard, to make the biggest impact at the most critical period of time before a bunch of vendors come in and deploy proprietary products around healthcare processes that don't interact in a care without boundaries manner. So 2 main aims, right? Assure that care without boundaries, which is not a technology thing, which is a human thing, exists in a standards-based open source way. And secondly, start to put some structure and scope around automating business practice guidelines, but also automating away the increasing number of menial IT tasks that healthcare providers, all of them, are overly burdened with in an increasingly disconnected world. So again, huge congrats to Pawan and Amy and Carrie in moving it forward. This next year is when we change things, when the idea of standards-based business process automation for best practices and for helping the human health IT worker become a very serious reality. So if everybody's been waiting for a time to push forward and to make it happen, it is now, and I'm really excited to work with you on it the next, 12 to 10 years. Who knows? 12 months to 10 years. To you, Pawan. And thanks.
Here. Nice, Shane. Yep. Excellent.
All right, Tracy. We'll flip to the next slide. And Pawan, if you just give me just 2 more minutes, and then I'll turn the time over to you. Okay, so folks, thank you, Shane. Please go ahead.
Sorry, I wanted to back up just to Shane for 1 quick second, because there was a question that came in that I think targeted him. So the question was from Diana. Are there already thoughts about IHE profiles that we might want to create? Since you mentioned IHE in the collaboration, Shane.
IHE is exquisitely interested in the next ramp up to HIMSS of next year and having a BPM plus health track there. It could be anything from a hackathon around an idea. Maybe that hackathon is around building profiles. Maybe that hackathon is about implementing profiles. IHE is also tied at the hip because of a couple of people to HIMSS. So IHE and HIMSS now, from a strategy perspective, have taken, are changing focus as they move forward and beginning to say, we are no longer a convener of interoperability. We are now a thought leader and a driver of it, and they love the BPM plus health story. Diana, I love the idea of IHE profiles. I'm going to clearly say I don't know enough about them to say yes or no, but if you wouldn't mind pinging me offline, I'd love to grab some more information about that, and I can maybe queue up some conversations with their leadership. So thank you for the question.
Thanks, Shane. Back to you, Amy.
Okay, thank you much. And for those that are on the conference call, the video, that are on the authoring work group, some of this was new information, hot off the presses. At our next meeting, Shane and others will be there, and we will be again working on integrating the groups and executing on the aim of the clinical steering group. So more to come. And those minutes again are out on the Confluence side. I see that Ken has posted, or Tracy has posted, the link to the site, although most of you already know how to get there. So I just want to recap the purpose of the authoring work group, because we've worked on this. We have a new aim of our work group. And I am going to read it just because this is important. We have co-chairs of all of the other work groups, and I want to be sure that everybody has heard this. Does not mean that we won't have additional descriptors, bullet items, but this is our new target, our overall umbrella, if you will. We have an aim, and that aim is to advance our discipline and to use formal methods based on BPM plus open standards to promote the business value, create and share best practices among healthcare professionals and organizations. And the first and foremost thing that we are doing as an authoring work group is we're not creating content, but we are building that first deliverable, our business case. And we have developed our draft of our target audiences. We are doing some additional great work. We've been asked to map and gap against existing deliverables like the guidebook, and we're documenting that in Confluence, and we'll be passing that information off to the appropriate individuals and work groups, as well as if something comes up in the work group that says, oh, that needs to go to the adoption work group, we're documenting that, and we've identified liaisons to the other work groups. So I just want to leave you with that, in that we are executing, we're learning, we're listening, and it's our goal to deliver on the business case for our target audiences, as well as our step-by-step guide. Those are the two primary documents that we're working on. And then as the clinical steering comes together, our first use case is where I would leave it. And I'm not going to read this entire slide. I'm going to turn things over to Parwan, because he does an excellent job of helping wrap us up, summarize, and articulates, because he's been on this team and co-chaired last year, and you guys accomplished so much, Pawan. So please, sir, take it home for us.
Thanks, Amy and Shane, and good morning, everyone. This is Pawan Goel. Just for disclosure, I'm an otolaryngologist by training and currently work for American College of Emergency Physicians that represent 40,000 plus physician community. So our goal here, as Amy described for the authoring group, is not to build content, but pick up content from other areas, which could be specialty societies such as ASAP, American College of Surgeons, or others, who have internal work groups that are working on suggesting certain use cases and building content through use cases. So some of the examples I will use from ASAP perspective is currently in response to COVID. ASAP is working on developing use cases and clinical practice guidelines for tele-triage in emergency department, sending patient into a safe home environment after they are suspected with COVID and a test has been done. Or if a patient needs admission, what is the risk stratification of the patient, and based upon each of the risk category, what kind of clinical interventions are required for those patients. We have recently been reached by the cruise ship industry and CDC to build guidelines for cruise liners moving forward in response to COVID. So those are some of the examples of the use cases and the clinical content and the practice guidelines that will be developed by societies and physician communities or hospitals. Once that content is built, then it comes to the authoring group. The authoring group can prioritize each of the use cases and see which will be relevant to the largest target audience. As Shane described, our audience are not only physicians, but we also cater to hospitals, IT industries that are building solutions, or EHR vendors that are integrating those practice guidelines. so that we do not have a burden of documentation on our physician. The goal for the authoring group is to take those guidelines and help them make computable, make them executable against standards such as FHIR or other HL7 standards that may be applicable for a particular use case. So that's where we are focused on, and as you will see on this particular slide, that we have a very busy agenda here with all the guidelines and timelines and some of the action items that we want to achieve. But we cannot do it without your help. So we need your volunteership, leadership to join us, and also send us questions and review our artifacts that will be helping the other 4 groups. So we are kind of starting point for the BPM Health Plus, and the other 4 groups pick upon our deliverables that become their input. And very thankful to Shane for taking leadership of the clinical group, because that is absolutely necessary. We need clinical expertise as part of this team, as well as technical expertise. With that, let's open up for any questions. And Amy, back to you.
Thank you. And it looks like no questions just yet, but we'll keep that questions box open if they do come up. Thanks, Amy, Shane, Pawan. The next working group is the implementation/vendor working group, which is chaired by Bo Dagnall from Perspecta and Ken Allgood, HealthFlow.io. Ken and Bo, you're welcome to step up on the stage here. Your turn.
Okay, thanks, Tracy. Bo, I figure we'll probably just pinch hit this back and forth. If that sounds good, sir? I think Bo's on. Okay. Well, welcome everyone. Thanks for joining us today. This is Ken Allgood with HealthFlow.io. Co-chairing this with Bo Dagnall from Perspecta. He actually kicked this off, and I joined him at the end of last year to following our kickoff that Ken Rubin mentioned earlier, to take it into the new year and prepare for HIMSS, which was quickly canceled. We have been going through a bit of a storming and norming effort associated with the implementer working group. We were previously scheduled to run at the same time. A lot of the COVID response stuff was, so we had limited attendance initially, although we had a good solid core that allowed us to move forward, establish some of the things that are on the screen in front of you right now, specifically identifying parallel standards related activities outside of BPM, and proactively starting to engage and align with current activities. Specifically, this is touching on other engagements that are out there, standards related for testing of standards-based models, specifically around information, characterizations and depictions, as well as clinical workflow. So being able to touch on these things that are already ongoing out there, and be able to identify points of contact and leverage the learnings in those groups. In fact, on the last session, we had the benefit of an attendee who was able to join us, since we shifted to a different day, from England, who brought in some working group content from an existing effort there that NHS is engaged in. So the intent here is to, again, leverage a broad swath of attendees, and by rescheduling to a different day, we're hoping to see more attendees. We certainly saw more the last time around, and be able to pull in existing activities that are already going out there to better inform the guidelines and recommendations that we make to the other groups, specifically authoring and methodology. Our goal, even though it's not, I think it's on the next slide, but our goal, as it's been defined by Ken and by the BPM, yeah, there it is up at the top. Our goal is to test, validate, and ensure models are authored, specified, and deployed in a way which helps to simplify and enable adoption and use. Having a standard that well describes things but is incredibly difficult to implement or doesn't offer the right value proposition to implementers reduces adoption and implementation dramatically. It doesn't matter how good the standard is, if you make it hard to adopt and implement, if it doesn't offer that kind of trade-off from a value proposition perspective, if it carries more weight up front All of those things can restrict adoption. And so that's part of, that's a big target in our activities, is to really nail down how can we ensure that what is depicted at the right, or is depicted at the right levels of detail and provides enough flexibility to where implementation in the real world is, number one, doable, offers a value proposition outside of simply, describing it well, and is able to optimize and really help drive forward on the vision, some of those visions that Shane and Pavan spoke to earlier, around really reducing some of that cognitive load, reducing a lot of that data monkey task, if you will, and a lot of the administrative back end. Again, you can describe it all you want in the model, but making it, the key is making it easy and offering a value proposition to the implementers to increase adoption at the edge, if you will. If you want to go back, Tracy. Okay. Again, current activities is identifying those elements, developing the reference implementation model and use cases for model enhancement and validation. We have a couple of reference implementations that we're starting with, and the goal is to run through those from end to end and identify at each touch point specifically what is needed and existing standards, things like that that already exist out there. Also identifying any tripping points that we wanted to, or tripping hazards, if you will, that we want to take into account around recommendations that we can then feed back to the modeling group, to the tool group, and to the methodology group. That coordination across the working groups is going to be critical for us moving forward as we identify, those issues which will reduce the model from achieving the level of value, computability, and really interoperability that we're all shooting for here. Additionally, we're identifying, reviewing the implementation guide, its existing content, and providing recommendations and updates for that. We've already started documenting some of those considerations, and the intent is to use those reference implementations to then drive those out further and distill it down to very discrete recommendations to hand off to the other working groups. And documenting governance lifecycle recommendations. I believe Amy mentioned earlier that that has been a critical area for the authoring group to focus upon. We recognize that same responsibility and requirement, and we're making recommendations and providing that back to the larger group for introduction and inclusion in the governance recommendations and structure that Ken Rubin mentioned earlier. Next slide. And Bo, I'll toss it off to you if you're available. Okay. I thought I saw him online. Tracy, is he not online?
Yeah, he is online. I was just looking to see if his mic might light up. I'm not sure, but he is on, but I think can't connect or stepped away. Yeah.
I'm a poor substitute for Bo, Shane here, but I work with him daily on these things, and I talked to him about this ahead of time. Ken, you want me to throw in for him there?
No, well, yeah, certainly. If you feel like jumping in, Shane, go for it.
Well, I mean, just to your point, there's been and I think what he really wanted to emphasize is the fact that there's been a large community of technology vendors, standards-based technology vendors, like Ken and his team from HealthFlow.io, like Teresa Tech, like MDIX, really across the community that are putting their time and their effort forward and to meet the clinical needs and to meet the clinical communities through demonstrations of clinical practice guidelines, the CKD stuff in particular. So, just really highlight that there's been a tremendous amount of work between the technologists and the clinical communities led by Ken and Bo, through this work group that's been moved forward. So anyhow, he was going to say a bunch about that, but that's a poor substitute. Just let me throw that in there if you don't mind.
No, I appreciate it. Thanks. Thanks, Shane. And that really is the core of what we've, as I mentioned earlier, that Stormin and Norman effort of really, number one, we were all focused on preparing for all of our expositions at HIMSS and really showing this stuff working. We shifted then to an online review for that, but that also gave us the opportunity to step back and really define what it is we're trying to do and put those connections in with the other working groups to ensure that as we discover these issues towards implementation, any challenges that may come into place, we have a mechanism and a forum to be able to push those back in a structured way, not just via phone call, but actually have a capability to source it to the other working groups so they can leverage that knowledge and those learnings. And to your point, Shane, be able to, we've seen a growth and hopefully, as I mentioned, shifting it to a Friday meeting session versus running counter to the COVID placemat sessions. Will also, it certainly was last week, it will enable other groups to go ahead and join us. We did see a bump up with additional vendors joining the last session. So what is going to be critical for us is seeing a robust response and engagement on the part of those vendors that have the availability to join us. We need your inputs, we need your feedback. Again, we have a broad swath of past experience. We've got a good representation on the group now, but we could always use more. And being able to have that collaboration ensures that those learnings and the information we feed back to the other working groups, those standards we then develop and then drive forward, those will be in the best position possible to really help us drive better clinical care via these automated workflows and standards-based health exchange. So that's really all I've got right now. Any questions?
That was great, Ken.
All right.
All right. Let's see. Get control back. Okay. So the third working group. So this is 305. The methodology working group is co-chaired by Robert Lario with the VA and University of Utah, and Steve White, Stevens Institute and BPM Advantage. And I believe Steve White's going to be taking the reins here to give us an update on the work under methodology. Steve, welcome.
Sure. So the methodology working group is a little different than the other ones in that it's really embedded within the OMG work. So the work we're doing is really in advancing this BPM Plus standards rather than utilizing it that the other working groups are doing. So what we're doing is taking the three basic standards of the BPM Plus and trying to improve those and also add other standards to help deal with the packaging and distribution and other aspects of clinical guidelines utilizing the BPM Plus standards, and also and trying to ensure that they work well with the other standards in the healthcare community, such as the HL7 standards. So the work we're doing is in two different task forces within the OMG, the Healthcare Domain Task Force and the Business Modeling and Integration Task Force. And what we're trying to develop are four standards, three of them listed here, that will be basically added to the BPM Plus stack. So BPM Plus has three standards, which are BPMN, CMMN, and DMN. And we're developing new standards to be added to that list of standards. So one of them is the BPM Plus Knowledge Package and Notation, KPMN, and that is for ways of adding metadata and organizing a set of other BPM Plus models to deal with a particular topic, such as hypertension or diabetes and so forth. So how do you know what to search for if you have these clinical guidelines stored somewhere on a server or in some sort of repository? Situational data model and notation is based on requirements we encountered while working with the BPM Plus standards in ways to help with the development and maintenance of the data that is used within the other models. So it's really a supporting standard. And then there's also pedigree and provenance. And that's actually had been going on in the OMG for quite a while. And we're really pushing forward with it because certainly pedigree and provenance are important for dealing with the clinical guidelines and other aspects of BPM Plus modeling. So that's going to be also a key element of the stack. Also,
Steve, it's Tracy. I just wanted to let you know that Robert is on too. So if you'd like, he offered to help co-present.
Oh.
Hi, Robert.
Yeah, Robert, if you want to.
No worries. Go ahead.
Okay. Another aspect of the working group is the field guide, and that was mentioned earlier. And I think Ken said that 300 downloads of version 2 have been taken from the site. So we're planning work on version 3, and that would be including information about how to deal with these new standards that we're developing, and just advancing that particular field guide as we go forward. So that we don't have a specific timeline for that, but hopefully by sometime next year we'll have version 3. So I guess we can move to the next slide. And actually, Robert put this slide together, so it might be good for him to talk to it.
Yeah, so I'm Robert Lario. I co-chair the methodology effort with Steve. I think Steve pretty much hit on the 4 major activities that we have in flight. I think we're targeting an initial submission of an RFC for the 3 major changes or new standards, knowledge package, situational data, and pedigree and provenance, targeting that for this December. And we do try to hit sort of a release in March. We are trying, we are hopefully going to have something for March 21. That gets down to some of the risks. We are very busy and got a lot of things going on with just getting these submissions ready for December. Admittedly, we've not been putting as much time into the field guide, but the idea also is that some of the assets or artifacts created as part of the submission would find its way into the field guide. So we're doing okay, but we can always use some more help. We definitely could use, perhaps on our calls, having a little bit more representation from the clinical expertise, subject matter experts. We have a lot of great technologists on the call. Sometimes we don't have as much subject matter experts as we might need or should have. I think another risk area that we're facing is, as part of the submission for the RFCs, we also want to submit what is an XSD as part of those submissions. Those XSDs are a formal structural definition based on the open standard of XSDs. And there are some challenges. We are developing the standards using UML and the magic draw tool, and that's extremely helpful to be able to do that sort of in the cloud. We can share models, everybody can see and comment and add and adorn, but the tools don't generate the XSDs directly. They do produce a lot of it, but not in a fully compliant XSD format. So we're going to have to go in by hand and make changes, modifications, and updates. We are hoping to work with some of the other submission teams that have confronted sort of the issues of trying to create an XSD for their submissions. There's some technical questions that we're running up against and how to represent the meta models in an XSD format. For example, XSDs don't support multiple inheritance, and we've got issues around redefinition, which are necessary in our meta models, but problematic when trying to represent that in an XSD, and will require us to go in by hand and make some of those changes and updates. I looked at these other sections, deliverables, next steps. I mean, we meet pretty much every week on Tuesdays and Thursdays. we have some, turnout sometimes is just a couple of us to a dozen of us. We certainly would welcome more participation. Deliverables, what would be deliverables, I guess I should have put in there, would be the RFC submissions, but we're targeting that for December. I think we're looking for alpha releases in September. I guess the other thing I should comment on is that one of the risks is the way an RFC is handled with OMG. And RFC is there's an RFP process, an RFC process. An RFC process is where a group is submitting a solution to a particular problem without necessarily going through a requirements process. What could happen is that we submit the RFC in December and another group, organization comes forward and proposes an alternative solution, which would then unseat the RFC. But we are managing that, and frankly, that's okay, because what happens then is the RFC that we've generated becomes the requirements for an RFP, and so it's possible that we might get pushed back, and then we'll have to convert our RFC submission to an RFP process. But that's something that we are planning for if that in fact happens. I think that's all I have to add. Steve, did I cover everything?
Yeah, and just to your last point, we're hoping that in September we can work with the OMG Architecture Board, at least advance ahead of time what we're planning, and just don't throw it to throw it at them at the in December. So we might be able to get some feedback prior to our submissions to see whether the RFC or the RFP process would be accepted by the Architecture Board. So hopefully in September we'll have a better sense of which path we'll actually take. And it might be that one of the specs might be RFP and the other ones are RFC, and so we just don't know the combinations yet.
Yep.
All right, thank you.
Okay, thank you guys. Yeah, great. And just for everyone online, so the Object Management Group, or OMG, the standards body, we meet quarterly. So September is a Q3 meeting, December is Q4, and the Architecture Board oversees specifications and that process. And RFC stands for Request for Comment. So it's when you submit a straight specification. And as Robert had explained, there's a bit of a longer process, if you start with an RFP and go through those steps. So there are two different ways to submit specifications to the Architecture Board, and that happens quarterly throughout the year. So thanks for that background. The next working group is institutional adoption. This is chaired by Jane Shellum, Mayo Clinic, and Teresa Cullen, who's just taken on a new role as Public Health Director in Pima County, Arizona. So Jane's going to be giving the update today from adoption. So welcome, Jane. Oh, we can see you. I just think you might be muted. But...
Yeah, sorry about that. I was just saying that it's great to be with you guys virtually, but I miss seeing you in person. But it's been a fun experience being part of one of these working groups. And what's really good about it is what the other group leaders have mentioned before is that these groups really interact. So Shane started out by talking about the importance of having these best practices in caring for patients, and how authoring clear and unambiguous best practices that are shareable will help with the adoption. And then we move into the methodology, where Robert talks about how we package these things up to really make them shareable across organizations. And then we talked about the importance of implementation and having technical solutions that can ease the process of adoption. what the adoption working group does is really kind of look at that last mile of how do we get these shareable clinical pathways to the patient. So just for a little background, the goal of this group is to increase the adoption of BPM plus shareable clinical pathways with the goals of providing decision-making and cognitive support to healthcare teams, to advancing clinical quality, to providing reuse of these important knowledge assets, for improving patient safety and lowering the barriers to implementation. So that's really the piece that we're focusing on. Right now, what we're working on is tools that can help organizations with the adoption of these BPM plus models, these shareable clinical pathways. And while the technology, as the implementation group said, is critical, there are a lot of other factors in organizations that affect the success of adoption of these shareable clinical pathways. And so we've been focusing on developing an institutional adoption readiness assessment and maturity model so that adopting organizations have a tool to understand their current capabilities for adopting these best practices and identifying some areas that they may need to attend to ensure their success. And the second piece that we're working on is an institutional adoption playbook, which is a kind of a how-to guide for implementing these BPM plus shareable clinical pathways. And I'm just going to put in a quick plug. We have a working session this afternoon that will be focusing on these activities, and we're looking for broader community input to the work that we're doing. So I hope you all will join us and get your voices heard and help us make these better products. Next slide, please. Oh boy. Okay. So the first one is the readiness assessment and maturity model that we're working on. There is a first draft of the model completed, and as I say, this afternoon, we will be looking for input from all of you on that model. The risks and concerns that we have right now as a group are what everybody has, which is that with the current situation with COVID and working with a number of healthcare and healthcare-related organizations, we have limited resources. People have a desire but limited bandwidth to attend to this. We're also trying to figure out how we can make this tool complete and useful, but keep it brief. So those are some of the challenges that we're facing. As I say, the milestone that we have for this project is that this afternoon we'll be trying to get input from all of you. We're looking at, in the next cycle, getting it out for review and then getting reconciliation of the community feedback so that we can actually publish this tool. Next slide, please. The other piece that we're working on, as I mentioned, is an institutional adoption playbook, a how-to guide to provide guidance for organizations who want to adopt these BPM plus models. Right now, where we are with that is that we have an outline in place. We have sections of the playbook that have been written in a first draft form. We've got people signing up to do other pieces of the playbook. We'll need to go through as a work group then and kind of massage it, make it all hang together. And again, then we will be putting it out for broader community review and input. And so that's where we are with the playbook. So those are the two major activities that our work group is working on right now. We have had a really tremendous interest and feedback. It's a great group to work with. It's the representatives of business and industry and academics and healthcare. It's just a really good broad group.
Thanks, Jane. And the work session this afternoon on the maturity model and playbook, that's 2:30 p.m. Eastern time. And if you'd like to join, if you go to our website, bpmplus.org, on the events tab, you'll see a link for the e-workshop this week. And then today, this afternoon, you'll see that work session, and you can hop in. We've slotted 2 hours for it this afternoon, so all are welcome to get involved. So thanks very much. Our fifth working group, the Academic and Professional Education Working Group, is chaired by Anna Orlova with Tufts University and Lee Wise, Clinch Valley Medical Center. And both Anna and Lee are on to provide an update on their activities. Anna and Lee, welcome.
Thank you.
Thank you, Tracy. And Lee, with your permission, I will start, but you please just chime in anytime, because what I'm about to present here always has a two-part: academic, that's my field, as well as professional education, which is the area of my distinguished co-chair, Lee Wise, with whom I worked extensively at the American Health Information Management Association Standards Task Force, where she was one of the leaders and subject matter experts. So with these two fold activities in mind, we focused over the past few months on three efforts. One is developing educational strategy, charter, and the roadmap, deciding why, who, how, and what are we, and who will be implementing this educational strategy that our committee is working on. And today, I'm happy to respond that we finalized our educational strategy charter and roadmap document. And after this conference, we would like to ask our BPM Plus staff to disseminate this document for the BPM Plus Health participants' internal review. And we would be very happy to see your feedback, ideas, recommendations on how we can enable this educational strategy moving forward, because we believe that that could be an essential part of our BPM Plus standards adoption. Our second activity that is led by one of our members, Anne Nguyen, is our stakeholder survey. And those of you who yesterday participated in the BPM Plus Jump Start session already got a flavor of what this survey may be about, because in collaboration with Robert Laria, we just decided to basically have the first part of this, or pilot of that survey during the Jump Start session, as it was very important for us to get our knowledge and experience with what actually we're planning to teach. And that Jump Start session yesterday really gave us a good feel about what content for BPM Plus training, both academic and professional, could be about. And we look forward for the feedback from the Jumpstart session participants on our Jumpstart session survey. And with that, we would be able to update the instruments on those survey and move forward with reaching out to broader stakeholder pool. The third activity that we are focusing on is our student capstone projects that we are launching in collaboration with Duke University School of Nursing and Informatics program. It was a very good alignment for us, because that particular project allows us to better understand how we could actually implement our educational strategy, taking into account that our students here are coming from actually user standpoint, not so much from computer science or business analyst or a system analyst standpoint. Yesterday at the Jumpstart session, there was stated that the primary audience right now for BPM Plus is more people on the vendor side, the business analyst and system analyst side. However, in our educational strategy, we strongly believe that the success of interoperability is laid on the shoulders not only vendors, but also on the end users, such as doctors, nurses, and collaboration with those informatics programs across the nation actually will help us to propagate BPM Plus training into the academic settings where our students could be familiar then and have experience in defining the identifying the clinical guidelines, defining the business cases and the use cases, solutions for a particular problem that is presented in the business case, defining the workflow and data flow requirements, and through this waterfall of concepts, which also comprise those artifacts that we are right now working on building in our educational strategy. It would allow us to enable this train the trainer program not only within computer science graduates, but also in informatics programs, informatics and analytics program graduates, which would be oriented or targeted to the end users, doctors and nurses. We strongly believe in that, and that opportunity that we have right now with 3 Duke students capstone projects is really a great start. We're running it as a pilot. Students also aware that we are in more like research and development phase on how this future capstones could be enabled. But I think it's a really good and promising start. And what's most promising about that is that though we've been doing these students capstone projects only for a few weeks, we submitted the presentation proposal, poster presentation proposal to the Mobilizing Computable Biomedical Knowledge Conference. That's the annual conference of the National Library of Medicine, where various academic programs and researchers are really presenting their ideas on how data, information, and knowledge could be computable. And we feel that our contribution from BPM Plus educational standpoint could be really a good addition to that conference. And we were right. 3 of our proposals that we submitted, one by the students themselves in collaboration with the committee members, then the presentation from the committee, as well as the presentation from one of our members on the particular tools to be used in training of the students. All 3 were accepted. And this is just one example of how we see we can reach out our academic partners and enable that particular content, such as BPM Plus, be taught in the academic curricula. I would like just to stop here and see if Lee would like to say a few words about our ideas regarding professional educations and specifically our presentation at the AHIMA annual convention in October. Lee?
Yeah, thanks, Anna. Yeah, I had 2 colleagues, one in the physician practice consulting as well as a health information manager on acute care, attend Jumpstart yesterday, and I've received feedback that they are both really interested in it. They have to chew on it. There was a lot of information that was given to them yesterday, but they do see that it is definitely a positive for the industry. So hopefully we'll hear back from them and we'll be able to pull more people in as well. We were also very happy to have our presentation be accepted for AHIMA. It's going to be all virtual. We're still waiting to hear back from AHIMA on how we're going to be able to present it, but it's going to be a wonderful, wonderful presentation.
Thank you, Lee. And I just would like to bring up another partner that we identified in our educational strategy, and this is standard development organizations. Therefore, I'm very happy to see today's presentation by Chuck Jaffe and see that HL7 is on board. But I think in the earlier session, there was a question about IHE, and I would like to say IHE stands for Integrating Healthcare Enterprise. And I just would like to say a few words about possible collaboration with IHE. In fact, 10 years ago, there was already a first attempt between IHE and OMG to collaborate, and several of us actually wrote a white paper on mapping service-oriented architecture to the IHE integration profiles, which was a very successful project, and informed the IHE community about activities that OMG is doing, though I believe that at that time it was still feelings that user role could be just really replaced by vendors in terms of setting the requirements and formulating both business processes and the use cases to be addressed. At least that was a standpoint of IHE at that time. However, that standpoint changed as soon as you get into the adoption, and you just realize that by not opening up that skills of formulating their business requirements, their use cases themselves, you're really limiting your pool of stakeholders just only to vendors. When the users are left to be upset, confused, and sometimes is just distracted by the good deeds that, for example, BPM Plus is offering for them. So even back then, I think it was around 2016, 2015, where the IHE truly recognized the need just to find a way to hear from professional associations, champions in medical and nursing community. And the result of this work was several publications that we wrote about business cases and the use cases and the user role in enabling their participation in formulating those basically informatics concepts. And I'm very happy to say right now that, in fact, in our work that we're planning to do at AHIMA, demonstrating our patient registration business case and revenue integrity business case, we're actually using the standards, content profiles, and the white papers that were developed by IHE. And I feel that linking the BPM Plus artifacts, business requirements artifacts to the technical standards that enable technical interoperability is really good way for us to empower end users and satisfy their needs. I would like just to ask Tracy to proceed with our few slides that you see, you will see in the as we are moving forward. And this is a few quotes from our educational strategy. As you can see there, that our target audience, we believe, is not only business analysts and vendors, but also there's some graduates from informatics and analytics programs. And more importantly, this professionals that are working today in healthcare organizations. We group them under this clinical documentation improvement movement, CDI, which is a movement that is on the rise in every healthcare organizations. We're building this because we feel that the users has benefit tremendously through their participation in the business process formulation in the standard way. And what we're trying to develop here is just to enable the adoption of our standards to empower this workforce through our educational resources. And on the next slide, Tracy. So you see our goals here formulated, our objectives focused on academic and professional educations. And as I said, with our participation in the conference, Mobilizing Computable Biomedical Knowledge next week, and AHIMA, we are beginning reaching out to this quite distinct community, but the community that actually could come together and learn from those particular content we've heard yesterday at the Jumpstart session and other artifacts developed by other groups. And the next slide, please. We, at the end, would like to develop the following products and services, and we hope that each of you, though maybe not a member right now of our committee, but still an expert in the subject matter experts in BPM Plus, could help us build those resources such as academic courses, professional development training, certification, on-the-job training, online tutorials and materials for future educational webinars, presentations, and online training, BPM Plus educational toolkit, and become our faculty representing academia, healthcare organizations, and vendors. And I believe that this is our last slide. Oops.
There's a little bit on the survey if you want, but I know you
okay,
covered
and
that.
I think it would be good to show the survey. So phase 1 happened yesterday, as you can see by dates. And now we are, after collecting information from the Jumpstart evaluation, we will be moving into phase 1 of the survey, where we will still pilot the instrument with the selected universities and healthcare organizations, then expanding our audience moving forward. Making phase 3 is basically continuing activity that would allow us to solicit the feedback on those various products and services that we will develop. And one thing is just, I believe you cannot see on this stakeholder survey, though we are starting with the survey of the content to teach. Another part of the survey is the survey of various tools that will help us to teach BPM Plus. And we look forward for our demonstration session tomorrow to learn from those vendors who are offering their tools to use or teach BPM Plus. And for that matter, we will be reaching out to them to develop like a second component in our survey that would enable teaching the students not in some kind of theoretical way, but in more cohesive way when all these different artifacts, where you can see them on the next slide, which are clinical guidelines, clinical pathways, models, standards identified, they all could be just stored in those tools. So we're looking forward to see demonstrations tomorrow, as well as expand our activities that those education toolkit that we are just thinking to develop could be built together with our vendors offering those tools. Thank you.
Thank you. Okay, Ken, are you back on the line? We had a question come in the last segment here. Ken was going to give an update on our COVID-related projects, but I thought now might be a good time to just pause for a second and take a quick question.
So Tracy, I was looking at the question, and I think that's going to bring back in Jane. So why don't we go ahead and do the COVID update and then just open the floor to all questions? I think that might be easier.
Okay, sure. Let me bring up here. There you go.
Okay. So we've got a deep dive session on our COVID project tomorrow. So I just wanted to spend a second just kind of teasing what we're doing. So first, well, these are being kind of sponsored under the BPM community. I should note that the COVID projects are not really BPM focused. The intent here wasn't to score points. The intent was looking at a global pandemic and taking a really rich, thoughtful, insightful community. How can we do some good? And just looking at the landscape of what's happening around COVID, where can we do the most good? And we settled in on 2 different activities. This is focused on what we're calling the placemat project. And then there's a second activity around a frontline care worker emergency department assessment tool. So I'll spend most of the time just giving you a sense of what these 2 things are, and then we'll transition to questions. So what is the place? I'll focus on the placemat project first. The placemat project is what we're calling the COVID Navigator. It's a tool to assist in the browsing and discovery of COVID assets. So the problem we're trying to solve is we've got these changing guidelines that are popping up all over the place, and to use the catchphrase, it's like 1,000 flowers blooming, right? And there's no one place to look to figure out where that guidance is. It's scattered all over the internet, and it's really hard to discern good guidance from bad guidance and curated stuff from uncurated stuff. And when you do find things, it's very, very difficult to figure out how the pieces fit together. So the intention of this placemat, and the idea is it's something kind of simple to help people navigate this myriad of stuff and start to find similar or related assets. So the key points, moving to the top center, the top 3, well, I guess it's 4 things. The effort launched, about a couple of months ago, and has been meeting, very frequently. In particular, for the Navigator, we've had a group focused on kind of the metadata. What information about these assets are we going to capture, and how does that work? That group has been meeting as frequently as 4 times a week. So there's just a massive amount of effort that's been going into this. We've got international participation. We've got folks that have been engaging from Australia and New Zealand, as well as many in the US and so on. The meta model at this stage is fairly well baked, and we believe that we're nearing kind of an alpha-ready version. We'll be testing that model over the coming week or so to validate, whether it actually is fit for purpose. Similarly, on the user experience and design, we have a preliminary design concept that's reasonably far along, and we've actually started to do prototype implementation against that. We're exploring a hybrid approach in terms of how we pre-populate this. So once we figure out, what is it about these assets that we need to be able to navigate to allow a consumer to find what they're looking for, at some point we've got to actually populate the tool with real data, about real protocols. So the intention is to do a bifurcated approach. One is to bootstrap existing things and get a small army of folks that are willing to do classification of these assets to cover the backlog, working with the groups like we were just hearing from Anna, and outreach into the academic side of things. And then the flip side is collaborating with others in the industry that are already standing up assets, like the EBSCO portal, for instance, to see if we can't get data feeds from some of these existing troves of content that we can then augment to include the fields that we're looking at. So we've got what we believe is a long-term sustainable approach, but we have to prove that's going to work. We are asking for help, in particular around the development side. So there will be basically a website portal on the back end. We need some JavaScript help. We need some hosting help. This is all pro bono work for everyone involved. So don't volunteer with the idea of this being a revenue stream for you. That's kind of the wrong expectation. But if you want to help contribute something to this global crisis, this is a way for you to add your voice to the choir and put something out there that can really impact lives. Risks and concerns. we're not at sustainability, and we need to make sure that this will not only get an initial version out there, but that this can be long-term sustainable. We have ideas how that's going to work, but at the end of the day, they're unproven. And there's a big risk about how do we get the word out about this thing, and certainly open to help and ideas there. I'm not going to walk every single cell on this sheet. The briefing format here is intended that we can use these meeting over meeting, so that way you can just focus on the things that are different since last time around. But in terms of I will jump down to the next steps box, kind of in the lower third of the diagram here. We're hoping to get some sort of alpha release of this thing done in the next 2 months, and we'd really love to see this thing go live in the August-September timeframe. So that's what we're working towards. If you have interest in contributing to the tooling, helping with classification, et cetera, those are all activities that are going to be heating up imminently. So we have a deeper dive on this along with a demonstration of the first prototype tomorrow. So if you're interested in the topic, we encourage you to join that. The last thing I'll say on the COVID is around the app, the assessment app, and I don't know if Pawan is still on. If so, I'll throw it to him in just a second. The American College of Emergency Physicians has developed a maturity model to help identify when emergency departments are in crisis. And the idea of the second COVID initiative is to develop a mobile app that can be deployed, basically globally, to allow individual caregivers that are working in these types of sites to assess the current state of their emergency department en route to identifying what the principal risk items are, so that those risks can be mitigated to help keep that ED out of crisis. So that work is a little less far along than the placemat, but it is coming on strong, and folks that are interested, again, we will have a discussion of this tomorrow, and are certainly open to inputs and contributions. Pawan, if there's anything you want to say on the ED model, please jump in.
Ken, looks like Pawan had to hop off. Drew was listening in, but I'm not sure if he's tuned into the speaker audio portion. But yeah, that session tomorrow is 2 p.m. Eastern on the COVID projects.
Great. So do you want to take us into a couple of questions and then wrap it with the big finish then, Tracy?
Yeah, perfect. And yeah, Jane, too, this is more of an adoption kind of question coming in. Has anyone studied how these models of clinical guidelines and their representations would be used in practice by healthcare providers to ensure the form in which they are presented is simpatico with how they can be most valuable in use?
That's a great question, and that isn't something that our work group has tackled yet, though it's on our roadmap, is how do we measure the success of these things. We did have at Mayo a study planned on measuring physician cognitive burden for the presentation of data and cognitive workflows that are based on these BPM Plus models. And we are in the first phase of getting the baseline data for cognitive burden of physicians in making complex clinical decisions. That study is on hold right now as a result of COVID, but we anticipate having that pick back up later this year. I don't know, is there anybody else who's aware of any of these types of studies? I think it's a really important point.
Okay, yeah, the floor is open if others have. And also, if any other questions, feel free. We have a few more minutes. And while we pause, I really want to take a minute to thank our sponsors, gold sponsor Maximus, silver sponsor Perspecta, for supporting our last couple of workshops. We couldn't do it without you. We really appreciate the support. It helps us open up the community to both members and participants. And as we turn the corner on our first year in operations, it's just been so invaluable. So thank you so much. Looks like another question just popped in. Keith Butler is just providing a good source. Cognitive burden, see the work of, and it's a Mr. Zhang. Not sure how to pronounce his first name, but I can send this to you, Jane. It's Jiaijie Zhang, Z-H-A-N-G. His work.
Wonderful, thank you.
Burden.
That would be very helpful, thanks.
Excellent. And if you like what you've heard today and would like to get involved, we very much welcome your participation. You can join BPM Plus Health on our website. There's the 5 working groups that you can sign up for. We have a regular cadence now of meetings. Most meet every 2 weeks, some more frequently. Methodology, for example, meets weekly. You can also subscribe to our larger mailing list and follow us on LinkedIn. We're planning another workshop in September during the OMG technical meeting, the Q3 meeting. And hopefully we can run another one of those great jumpstart sessions that Robert Lario led yesterday. It's a good primer into the community. That's it for questions. Any last words, Ken and team?
Sorry, coming off mute. Let me just take a moment to thank all of you for joining us today. Reinforce that this is an open community, and we're better off with your contributions than without them. So please identify areas that are of interest to you, and we'd love to see you engage. I'd like to thank everyone that's been involved in the community so far. And hopefully this gave you a little bit of a taste for the diversity of activities that are going on. There's a lot going on, and we haven't done it justice today, but I think we've scratched the surface. And hopefully you see where we're trying to go and can help us not only get there, but get to where the industry needs us to be. So thank you, everybody.
Thank you, Ken. Okay, we're going to capture this recording, and the slides, we'll post them back to the BPM Plus Health website, and we look forward to seeing you on other sessions this week. Everyone have a great rest of the day. Thanks.